everybody in the room in one way or another works to on this mission of healing healthcare. And so today what today's gonna look like is about a half hour of just a discussion and me highlighting some data and things about well-being across the organization. And then we'll take a half hour and we'll do a little workshop where we just kind of flex a skill, an individual skill that hopefully will help you in your own well-being. So this, many of you were a part of the creation of this healing healthcare, so we may flourish and serve. But for those of you that weren't, our faculty well-being committee decided that this was our kind of mission statement, our elevator talk, our what do you do on that committee kind of way of communicating that. Because well-being can be complicated and has pendulum swung from a lot of individual wellness work over to like all system approach. And I think we're swinging a little bit back in that it's, it's both things. But as a committee, we really wanted to use that to kind of guide the discussion and be our North Star. I don't have any disclosures and have some objectives for today to recall the elements and prevalence of burnout, to recognize the importance of well-being on the individual, the team, and the system level, and then to develop some skills, individual skills to promote well-being. Okay, so why did I get into this work? Well, this picture right here is a little mixture of a bunch of the reasons I got into it. So, I look around me and I see an organization of people who work really hard, care a lot, are very kind, are smart, are motivated, and they really want to do good work and help people. And in that process, somehow in our profession, it is burning us out. And it's making people who never thought they'd be in this spot want to reduce time, do something different, invent something so that they become financially independent. And they're just, there has to be a better way. And I believe there is. I believe there is a way to do this healing work and maintain our own well-being and avoid burnout, but it's not gonna happen today or tomorrow. It's gonna take a lot of hard changes, a lot of undoing of things that have got us here. It's gonna take a lot of advocacy on everybody's part. And so, to me, I just really wanted to be a part of that solution. And I know in my time, we're not going to have a fix. This is going to be a long journey, but there seems to be no more meaningful work for me than to support our people so that they can do the good work. Okay, so a couple little interactive parts. Could you guys give me just some quick ideas of what is well-being? What does that mean to you?
Dreading coming to work.
Not dreading coming to work. Yep.
Sense of balance.
Okay, good. Yeah.
Satisfaction, fulfillment.
Satisfaction, happiness, and fulfillment. Yes. Yeah. So it remains this thing that you feel like when you're there, more so when you're not there, right? And so there's this whole spectrum of burnout, and we'd like to be not burned out, but then we'd also is not burned out well, better than burned out, but it's all part of the spectrum. So then what is burnout? Maybe dreading coming to work. What else is burnout? Apathy. Personalization is definitely a part of it.
The negative effects of things that you have little or no control over, especially in a system.
And what causes burnout?
Ambiguity.
Okay, tell me more about that.
So from where in my work, it's like if I'm not getting clear messages from what is wanted from me, then I kind of just I'm spinning my wheels and running in circles.
I can identify with that. And then I also, for me, because with the lack of someone telling me that I do things and I do a lot of work, and then someone is like, nope, and you're like, oh. Okay, shift.
Lack of boundaries.
Say again.
Lack of boundaries.
Lack of boundaries. Yeah, and what kind of boundaries do you mean there? Like time or?
Give me time. The volume of what you're saying. There could be boundaries on both sides. Frequently being placed in no-win situations.
Okay.
Siloing.
Yep.
Misalignment of values.
On, not on,
Well, you're always on.
always on.
You're always on.
Yeah. I don't have to be on call anymore. I just have to look at my inbox. What do you mean you didn't look at your inbox last night? Like,
Yeah.
you got 15 messages.
Yeah.
I'm always on call. I'm always answering.
Yeah, you didn't get do your in basket, so someone emails you and then you didn't see that in 3 hours, so someone texts you.
Hey, did you see that inbox that I sent?
Okay, yep.
Not working to the top of your license.
Oh, good. Yeah. Not working to the top of your license, all the forms, all the things, yep, and we lump that into this administrative burdens bucket. But that can mean a lot of different things for different people, not just clinical, but also clinical. The AMA just put out a webinar that's the front line is our bottom line. So that the title of that really resonated with me. Because there's a lot of people in our organization and healthcare who don't do clinical medicine, and their burnout, our burnout matters as well. But a lot of the work we do is focused on the front line and their well-being. Anything else?
The various forms of mental illness within the individual who is burned out.
Yeah.
Depressive compulsive disorder, perfectionism, anxiety disorders, et cetera, depression, all the different contributing factors.
Yep, for sure. People who are burned out are more likely to be depressed and vice versa. There's overlap. They're different things, but they definitely coexist. Thank you. Anything else? Probably if we made you think specifically to your line of work, right? Like when I do this with, this was our first question on our faculty well-being committee meetings, and everybody got to come with what burns out their departments, you know, and that looks very different for different people. But there's themes in it, and the themes tend to be, I'm not giving the type of care that I want to be giving. Sometimes I'm not proud of the experience our patients have, and those kind of themes ring through all the departments. Yeah, and you can see why that doesn't feel good. You're working really hard and you're always on, and you're not working to the top of your license, and you're not sure you're giving care that you're proud of or the best care that you feel like you could give. Okay, thank you. So when we ask in surveys what contributes, the same kind of things come up in our surveys, with the too many bureaucratic tasks as being number one for physicians. Too many hours at work, a lack of respect for administrators, insufficient compensation, a lack of autonomy and control. I heard that. Yeah, and it goes on and on. So this is the latest results from Carilion Clinic physician well-being survey. So far, we do ask 1 or 2 questions on well-being of all employees. on the engagement survey, but so far the physicians are the only group that we've done a deep dive on well-being. We just did that in November and December. Some of you participated, but this is our what we look like. So national comparison, so physicians nationwide are 43% burned out in 2024. That's actually a little bit better than the year prior. So for the last 2 years, we've started to see a little bit of improvement in that. And we're talking from like 46 to 43 over the last 2 years. And you know, that seems like a small amount, but when you figure out how many humans that actually is, it's significant. Carilion Clinic overall was kind of right at just above national average at 44.7%. And then here's our 11 clinical departments and where we scored. It's really helpful to compare departments to each other. It's even more helpful to compare departments to their national numbers, which is not on here. But for instance, in my specialty, emergency medicine, 44.5 is actually quite good. We tend to live at 56% burnout rate. For many reasons, probably our shift work and is a big part of that, but the acuity, we won't get into it all, but yeah, so that's actually kind of a bright spot for me in this, even though we're just kind of average up here. A couple of our departments had smaller response rates, or they're a smaller department. So for instance, the N on neurosurgery is 10, and so that is a little bit different than like the N on surgery, where 60 surgeons filled that out. So you can, you know, you can rely on some of the data of bigger teams and teams that filled it out had better response rate. Questions or thoughts on this? In internal medicine, we have some section data that Sarah and Carl have been looking at. I know we have some bigger sections in IM. We also have a little bit of section data in surgery. There's already too many numbers on this slide, but if anybody's interested in section level data, we can talk about that.
Did we connect with pediatrics as our bias to navigate the whys and
Pierce is here. He said, did we connect with pediatrics? Yeah, and Lori's the well-being director.
Well, we'll say there was only 9 people that responded on that particular, so, and we want to take that data seriously, but we also recognize that maybe that particular group may have been particularly overly overwhelmed or burned out, but yeah, so we did review that with our department faculty the other day, and we're kind of digging away at that.
that's acute and out? Are these numbers acute and outpatient? Okay.
Yeah, the whole department. Just physicians,
Yeah.
no APB, yeah. And part of what the experience in pediatrics has been difficulty recently getting people to engage, at least from the leaders. And so this was kind of another example. So to me, I'm not too reassured that that's not accurate. If we're having trouble getting people to engage, they may actually be those numbers, but we're not sure. And Dr. Pierce is handing over. There's work to be done.
But whether it's really 66% or not.
Yeah.
doesn't matter. You know,
Yeah.
Pretty well in the frontal of it.
For the next leader.
My wellness is really good.
For those that
I'm
don't know
hopeful that
that.
the next leader is coming from a gold joy in medicine.
Yeah.
So I'm really hoping that she's going to bring some other ideas, but Dr. Pearson and I have really been trying.
Okay, so a couple things about aspects that we know are protective against burnout. So people who feel valued by their organization are less likely to be burned out. And these were our, this was our numbers on who feels valued. So that's just over 50% of our physicians feel valued on a Likert scale. I don't know, What do people think of that number?
Sounds accurate.
Sounds accurate,
Sounds
okay.
reasonable. What do you think about the people you sit with in the elevator?
You're like, I believe that number. Yeah.
Things that half don't.
I know you hate to always look at the glass half empty with well-being, but we have a group of people who do, I mean, it's arguably some of the most meaningful work that should be valued, right? And whether it is valued, which we believe it is, but they're not feeling it, this to me just feels like such an opportunity. Like, how do we move this needle on feeling valued? So we asked the physicians at the January conference what would make you feel more valued, and they got together in small groups, and this is what they said. They would really like acknowledgements to be personal, less of like a general platitude of thank you for what you do, and more your direct leader or a colleague or a patient say, I really appreciated how you showed up like this, or when you did this, or good job there. Those type of kind of personal acknowledgements seem to be most appreciated. When they have an idea and somebody helps them make that a reality, they feel valued. And the opposite then is true, that when they have an idea and they bring it to people and it goes nowhere and nothing changes, and then they try again and then they try again, that makes them feel not valued. The physicians would really like to be able to reward and retain key staff and employees that they work with. So for instance, if there's at a clinic and there's one key person who makes that clinic run well, and we're about to lose that person because they can make a little more somewhere else, they want some flexibility from the organization to be able to reward that person and retain and keep them. And then there was just some talk at the conference about lounges, and how our lounges feel like workstations, and they don't really feel like a place where people gather and connect or get to know their colleagues. And then there's a reminder that that's just for our hospital employees, but everywhere we work, there's a potential to have a place where people can gather and connect. So whether that's at a clinic or when, it's not, many of our people don't work hospital-based. Okay, taking 4 weeks of vacation or more is protective against burnout. So here's a little deep dive into who takes what for vacation. So we have 5% of our docs, 5% of 700. So we have a decent amount of docs who take no vacation. We have another 5% that take 1 to 5 work days in a year. And then we have a bigger group that takes a week to a week and a half. And what we're aiming for here is 4 weeks and more. So maybe we'll count 3 weeks. We'll count, 4 weeks and more. So here, so 55% of our docs do take amount that's protective. But what about all these people? And why aren't they taking vacation, right? And we have access to care issues. We have in different pockets of the organization, we have policies and compensation models that incentivize people to not take vacation. For instance, if you're all RV, if you have an RV part of your arm, your compensation arm, then that's not corrected for when you take vacation. So anyway, it's very department specific. People's vacation policies vary, but it's worth taking a little bit of a deep dive in places to figure out how we can do better here. Having supportive leadership is protective against burnout, and we had a 71% of our docs felt like their leadership supports them in clearing obstacles to patient care, so it's pretty good. Working less than 55 hours a week is protective for burnout, and the physician group is not doing well here. So of our full-time docs, they're reporting 62 hours a week that they're working. And then of our people who self-report as part-time, part-time for our group is 27.2 hours. And then, so I'm like, is it really protective? So we ran a report to see how burned out are our full-time docs and how burned out are our part-time docs. And it looks like it is significantly better for our people who work 0.8 or less. There's a recent article I read that gives you by specialty an estimate of how many patient scheduled hours, how much real time that is. So if you're working in a clinic and you're scheduled 30 hours, that's 52 hours of real work. And so it's interesting because, we schedule people full-time many times on a clinical panel or clinical hours without really appreciating that you have to add another third to that at least for work.
Lisa, I've got a question. On that chart, how do you account for like putting information into Epic? All the, where would that come in that chart or that indirect patient care?
Yeah, no, direct patient care really is bedside, at the bedside, although you can see how that can be a little messy because people are oftentimes charting while they're seeing people. But indirect patient care and administrative tasks, people probably interpret it to fall into one of those categories. Seen that before. So other areas of opportunity on the survey are people who were 6 years out all the way to 15 years out, but particularly the 6 to 10 years out of graduation are particularly burned out. That group was several percentage points higher than the rest of us. So something happens when you've been working for about 5 years and you've got your clinical feet under you, or it's not clinical, you kind of understand how to do the daily work, and then you're probably really busy with life. That's what I'm thinking is probably playing into that. You're probably sleep deprived, but you're probably also wanting for more. You want to know what the next step is. You're thinking in your mind, am I going to do this same thing for 30 more years, or how am I going to develop my career? As is reflective in national numbers, our women are more burned out and feel less valued than our men. So here's our current clinic numbers. Our women are 48% and our men are 41% burned out. And then the feeling valued is about 5 percentage points different. And then we had significantly high time in the EHR compared to national numbers. Okay, so I had some key takeaways. We had some key takeaways from this. People want a voice in the processes that affect their work. Good ideas can get lost in complex systems. More meaningful recognition is always needed. And then manageable work weeks with regular time off is worth taking another look at. From a clinical standpoint, our electronic health record burdens are high, and they're probably our #1 reported driver. Patient flow and scheduling inefficiencies are having significant impact for many of our teams, whether that be ambulatory or in the OR or in the emergency department. People are feeling that. And a lot of that is you can't predict your own life, but also, again, this feeling like you're not doing a good job for patients. And anybody that's tried to navigate our health system as a patient or for a loved one knows that even when you're part of the system, it can be hard to get timely care. And then there's all these little friction and inefficiencies in the system that just kind of wear away at you with time. Okay, so I started to think about this a little bit. Like, medicine is hard in 2 ways, and I'm calling it the right kind of hard, the hard we expect when we go into medicine. The reason that it's so important for us to wrap around and support people when they have an unexpected outcome, or when they're having to deliver hard news, or whatever that may be, there's a right kind of hard that we kind of expected, and we need to continue to support people through. And then there's what I'm calling the unnecessary hard. So it's just so many things about it that just feel unnecessary. And so again, the right kind of hard is to me all about support. And that is going to be people in the room here are part of that support. But that's like, how do we support our peers? How do our leaders respond when someone's going through something? Do they even know about it? And then how do we chip at the unnecessarily hard? And there's lots of different ways we can do that. Getting rid of stupid stuff. Most people know what that is by now. It's the AMA program that kind of describes letting people come with an idea and supporting them in a way that helps them get rid of something that's getting in their way. We don't have a organization-wide gross initiative right now, but we have pockets of it around the system of teams who are working in this. We have a health informatics team that gets rid of BPAs. Hopefully everybody knows that, but they are constantly clearing out BPAs that aren't working correctly, or people know what BPAs are. Okay, for people who work clinically, let's say I put in, well, let's just say I sign up for a patient. I get this alert, it's a best practice alert, and it's like, alert, alert, this patient is a fall risk. Please fill out this form. And then I'm like, this patient's 11. Like, why is this BPA coming up? But then I have to it takes my train of thought, and I have to answer the BPA to get it to go away, or I can't continue my care. And so there is a little button up in the right-hand corner that is a thumbs up or thumbs down. I'm sure James knows about that button. He's a good feedback giver. And you can either give it a thumbs up, like that BPA worked for me, or you can better yet thumbs down it and say, why did this BPA fire for an 11-year-old fall risk? Like, that doesn't even make sense. And then the BPA team will look at it and either get rid of it, like that BPA is not working. Or anyways, it's a good example of getting rid of stupid stuff. Or pebbles in your shoe, that's another way to look at it. It's not the mountains that you climb that wear you out, it's the pebble in your shoe. Debunking regulatory myths, I think, can be so, sometimes it's like, why is it that way? Because it's a policy. Why is it a policy? Because it's a regulation. Is it? Can someone show me that regulation, and then nobody can really show it to you, but it's just been passed on by generations. So any way that we can question why we do things that don't make sense, we should. It takes energy, though. Continuing to work through Epic optimizations is going to be a key part of it. Looking at our work outside of work, why are people doing so much work outside of work? And how do we get rid of some of that? And then continuing to advocate at the national level and governmental level, because doesn't anybody ever feel like this, like I do? Like, really, is every health organization in the country, we're all doing the same thing. We're all trying to fix the same problems. And it seems like if there was more mass movement, if we could gather the voice of many powerful teams instead of everybody trying to fix this on the local level, or while everybody tries to fix it on the local level, there's also some advocacy. So that's all brings us to our well-being model, where we are focusing in these 4 gears when we're talking about how to heal healthcare. We're talking about making sure we support people for their personal factors, whether they have a mental health diagnosis, and we need to clear out some of the barriers to care and the stigma around that, whether it's making sure they have the right benefits to make sure they're taking care of themselves well, whether, and then there's these 2 big buckets, which our committee is really trying to focus on. And that is, what does our culture look like? Do we feel valued? Do we have a voice? Does our leadership communicate effectively with us? Do we feel like our values align with the values of our leadership? And then workplace efficiency and function is my favorite gear, which anybody that knows me already knows that's my favorite gear, because I'm an ER doc, and we like to be efficient. And that it's not just ER docs that want that. We all want to take care of as many people effectively as we can. Okay. Many of you are up here. Just a quick note that we have a director of well-being in each of our clinical departments now. And so this is the list. You can see who your representative is. If you if you do not fall in one of those departments, that's okay. You reach out to me, reach out to anybody. We also have our Wellness at Work team here, and they support all of our employees in various different ways. In particular, Lindsay McKinnon is our representative for our residents and fellows. And so she has recently put together a Wellbeing Champions pilot program where we are trying to model what we're doing on the faculty side. We know the residency and fellowship programs have their own well-being needs. And so finding champions in those programs to figure out how to make a difference in the culture and in the efficiency buckets. Okay, so that's kind of where we're at and how we're approaching healing healthcare. And I just wanted to pause before we go into our breakout to kind of see what's coming up for you. Yeah.
Has there been any discussions at a high level about a ROSE campaign at our system that you've been involved with?
There are discussions about that. We're talking about what that would look like. UNC has a pretty robust program, and they did a nice job of breaking out how many FTEs and what kind of people you need to run a program like that. It's actually not that many. You need a program manager, you need a data analyst, you need the buy-in of your health informatics people, because a lot of what you get is going to be Epic related. But we are talking about that. My personal goal is if we could have something up and running like that within a year where people can submit, and we won't get to them all maybe, but we could prioritize it and give people feedback on where we're at. Have you seen that done well or have thoughts about it?
I mean, I've heard about it and read about it, and I think it feels like something that would address a lot of those pebbles that people have no outlet for right now. And I think that I almost question whether you could just do it as a campaign one time without FTE and then just funnel work to the relevant people as a bolus, rather than waiting for 2 years to get FTE approval in a tight financial situation. So, but to me, that a lot of the impact, like you said, are the system things and the regulatory, imagined regulatory things and things that are that you fight the same headaches every day, and there's just no outlet to fix it.
I think it can be done as a baby step without FTEs. I think you're right.
But as a whole program, that's actually even better where it's continuous.
Yeah.
I've heard of it as a two-step campaign, but programs even better.
Yeah, I feel really strongly that I would want to support a program that closes the loop well. And I think without dedicated people doing that, that's the part I'm worried that where people would submit it and then it would be another safe watch. Where you're just not sure what happens.
Don't worry, they're not gonna get back to
Who's here? Yeah. What else is coming up for you?
I'm really thinking resiliency comes up. And I think about that, as in the mental health space, how do we build resilient patients when they face adversity? But how do we do that within our system, right? Individual and teams. Because if you have a team that's resilient, you as an individual are more likely to be able to handle adversity and challenges without encountering burnout. Like you may be under stress, but you have a team that you can rely on. And how can we invest in, because you can't build resiliency, but you have to work at it and you have to make people cognizant of it. And so how can we do that? And what have you seen that's been helpful, in this work in doing that?
Yeah. So resiliency in the well-being world has become kind of like a four-letter word because of the canary in the coal mine analogy, where for a while we just kept telling people to get stronger, and maybe if you did this workshop, maybe if you meditated, maybe if you and I can remember early on when I was sending out Healthy People Heal People emails, and I gave our group some mindfulness resources. And what came back to me was frustration and anger. And I have no staff, and I'm doing work I'm not proud of, and you're telling me to meditate. And so I'm not saying resiliency doesn't play a role. I totally think it does. I think from my standpoint right now, I really want to focus on system improvements to create a little bit of breathing room so that, and if people know that we're addressing those, then there's a little bit more acceptance of like, okay, while you work on that, thank you for working on that. Okay, but we have to like strengthen ourselves and get more resilient in the meantime. So that's the quick start to that conversation. There are a lot of resiliency tools that we have around campus that we don't have around campus, like compassion training and things like that, which I think could be really helpful. Do you have experience in something you think would be helpful?
Well, I've seen it more be helpful with teams. I wouldn't say like focusing on an individual, but like how do we build a resilient team? So if somebody is struggling, right, that how do other people adapt, recognize, and step in so that we're like, that we as a team can wade through anything that comes our way, right? And how do you feel that? Because then you're more likely to be like, this really sucks, and I'm really pissed off about it, but I'm still going to show up because I have a team that has my back and is going to help push me through those tough times. And so that's where I've seen it be really helpful. It's actually more of the, like, how do we build a resilient team that is recognizing each other and stepping in. And I'd say up and down, where are we advocating for ourselves? Are we, sharing with our teams? And then our leaders recognizing that, right? And then stepping in to say, what do you need? So.
I think you hit on some of it as a system and the predictors of burnout, that if we have staff working potentially less hours or on things that the things that they're passionate about, our staff in healthcare, physicians making it through undergrad, med school, residency, they're already resilient people. To get through to that process, to be an attending physician, you already have to be resilient.
Yeah, good thing we're resilient.
Yeah, and there's med students or residents that come out that are already burnt out because of the work hours of residents, and Lindsay is working on some of that for our residents and fellows and trying to advocate for those pieces. But if we take people that are already on the edge of burnout or more stress or whatever buzzword we want to ascribe to somebody and say, well, if you just did this, you'll become more resilient or you'll become less morally distressed, without changing some of the systems or the broader pieces, we're just going to continue in that cycle. And so I think that's a great perspective to have, to not just say like, we'll just give you more tools, go home and do this mindful meditation or go running. It's like when people don't feel like they have time to do all the things that's required for them.
Yeah, then they just feel like they're failing at wellness.
Yeah.
Yeah.
But I would say that's what we do with our patients too, though. Like, I mean, I feel like this happens all the time. Like, well, if you would only do X, Y, and Z, you'd feel better.
Lose
right?
weight, your back
Like,
won't hurt.
and patient, as opposed, flipping it, what do you need? Like, how can I help you? And
The resilient team thing is really important though, and it fits in the culture bucket. I think I've been part of my department when it has felt very resilient and has had, a certain type of leadership that made us feel strong, and we watched. And then I've been a part of the department when it's not been so much, and it's amazing how different you feel.
I'll say that 2 years ago, we tried to do a program that comes out of the Harvard Sim Center called Circle Up. That's very much focused on resilient teams and like how to get people to ask for what they need, how to take stock of that, how to adapt your team to those needs. And then there was also like a quality improvement process where at the end of every shift, you're supposed to capture like what went well, what went wrong, and have close the loop on follow-up. We tried that with 2 teams and it went okay. But I
think it was such a culture shift for people that people had a hard time really sticking with it. I'd love to talk.
Did you have champions in it that were like the
We had
lead for
champions
it?
who were in it, but it was, yeah, just asking people to pause for 5 minutes at the beginning and end of
And to do
shifts.
more, right? Like nobody wants to do
Yeah.
more at the end of the
And
shift.
it was hard to sell, like, this is gonna improve down the road, but you've gotta make it.
Anyone else need
there.
to?
Yeah.
No, I can.
Oh, you distribute?
Yeah, I'm just here to help you.
Okay, possible.
There, thank you. There you go.
Yes.
I'd like to make several comments. I really appreciate, I think you're focusing on the system, on the systemic things that we can maybe do to help the problem. Let me throw some things out too.
Okay, give me one sec.
I look around, I think I'm probably the oldest person in the room, okay? One thing is the marked indebtedness of physicians coming out of the training, okay? Second is, a lot of times I think physicians become financially overcommitted, they get second homes, they really overcommit themselves financially, which increases the risk for you to get burned out, stressed, because of their need to produce a certain level of income. And I wonder, in light of that, are there differences in burnout rates? Like, I think physicians of my age were more boomers. We were more interested in owning things and being more, wanting excessive to own like that. I think the newer physicians, millennials, Gen Zs are much less like that. They're more focused on lifestyle. They don't care about, they're willing to work less, they're willing to make less. In light of that, have we looked at burnout rates for various ages, boomers, Gen X, millennials, Gen Zs? Next thing is, I think preserving time off is very, very important for physicians' personal life so they can be involved in their family's activities. I love coaching baseball, things like that. I mean, whatever that might be, that needs to be preserved. My observation over the years, burnout rates are much higher, I think, in general internal medicine than the subspecialties of internal medicine. Why is that? Another thing, and I think that burnout rates are high in EM. I've observed this, and also in internal medicine, pediatric hospitals. Okay, and I think a lot of that is if your week on is really bad, if your week on is 12 on, 12 off for 7 straight days, it doesn't matter if you have a whole week off in between. That just stinks, and that's a horrible lifestyle. You can't do anything that week. You can't be involved in your family's activities that week. So even if you have a full week off, the only person that would work well for is like someone that doesn't have a family, likes to travel. It might work well for somebody like that to have that type of work schedule. But I think these are all things to think about when you look at the whole burnout picture. And I know we're focusing on systemic things here. I get that.
Well, no,
But these
I'm
things
also
impact,
focusing on that.
these things impact systemic issues. So
Yes.
just saying.
Yes,
Okay.
I totally agree. I've definitely had not enough time off to recover from a bad stretch where I'm coming into that shift with dread that like, I hope nothing difficult happens today because I don't know if I can take it. We definitely look at ages. The boomers are our least burned out age. It's more like 30% as opposed to in the 40s. So there's something to learn there. Yeah, it's interesting to think about a message of don't overextend yourself financially for Lindsay as she's, bringing in people to talk to residents and fellows about financial wellness. So thank you for all that.
There is some reasonably robust data looking at rates of burnout among med students and residents and their level of financial debt related to their student loans, specifically related to their student loans. So that is out there. There's a clear correlation between the amount of debt you're in and your perception of burnout that you can't leave. Yeah. You've got $250,000 out there. That's probably something that's probably a little different in your age population. It's pretty common though in younger individuals that most of them are holding on to more than a couple $100,000 debt before they leave residence.
See, I think
And it's not because they're riding a Ferrari. By the way. It's not because they're renting a Porsche.
No, medical school tuition should be free. There should be a 3 or 4 year commitment to either the military or an underserved area. That's the way it should be. I mean, that would take that's my humble opinion. Now they can buy out of that. Every place should have access to that. I think that's my opinion.
A bit of a reflection and a question was, the slide that you had up about the amount of time that your physicians are taking off of vacation time, they're taking off anywhere from, where 4 is kind of 4 weeks is the healthy space to be in. Is I just wonder when they're coming into departments, is how clearly is it being communicated to them? Like what is acceptable and what is recommended, and kind of where do they fall within that? Because I know personally, when I moved from hourly bedside into a salaried position for a couple years, I had no real understanding of that. And so I definitely would undershoot the amount that I would take off because I didn't want to be the one who was taking 3 weeks or 4 weeks instead of less. So I'm sure some departments, I'm sure it varies. Like I'm sure some departments very clearly communicate that, but just something to think about for
Yeah, what would it look like for your department to say, like, we want you to take 4 weeks off. We expect you're gonna take 4 weeks off. We're gonna cover your in-basket. When you have off, we're gonna credit you your average number of RVUs you usually make during that week so that it doesn't affect you negative. I mean, it just feels like a different conversation. There's an opportunity for different conversation.
and clarity, because then otherwise what happens is if you sort of go from that 1 week to 2 weeks or 2 weeks to 3 weeks, and in that 3rd week of vacation, you're still coming into it with a little bit of angst. You're feeling like you might be doing something wrong, or you might be judged, or you might be looked at.
Maybe I won't.
Even
put
if you're
a
not.
out of office email because then
That's right.
people won't know
That's
that
right.
I'm really gone.
Yeah, even if you're not being, it's not being looked at that way.
And how easy do we make it to take vacation? I mean, I know I'm in 3 different clinics. I have to find people to cover 3 different places, make sure everybody knows, make sure my Outlook schedule, my Epic calendar, like make sure everybody is like, that nurse practitioners know. I mean, it's hard to take vacation and make sure you've checked all the boxes. And then I also think it's not time off of work, it's 5 o'clock, right? Like, it's not just like a week of vacation. It's like your day ends at 5, right?
That's my pre-training.
Right, but we don't set that as a system to our patients or to our providers. Like I got a message on Friday and I was on call on the weekend, so I ended up seeing it, but the patient was like, so you'll let me know this weekend, what you think about these days. I'm gonna email you all weekend so you can give me feedback before the kids start school on Monday. And I was like, no, like it's obscene, right? Like at 8 o'clock on a Friday and I wish the system would like respond to that in some way, saying your physician works between 8 and 5. Your messages will be, read between 8 and 5, Monday through Friday. But instead it's like a text message chain. At any time of day they can.
Well, the system as a whole has put out that they expect you to reply to all of your inbox requests, et cetera, within 3 business days. So if you're wondering what the expectation is from administration, that is that.
Yeah.
Now, how you're supposed to answer her, and then the next 12 people that want that as the weekend goes on, that's when you have to decide, like, how much is it hurt to go on vacation before you come back? Because
Oh,
you
I'm
got
very good about like 5 o'clock. I'm not checking messages. If it's not an urgent email, I'm not responding. I'll respond to you the next day. But that's come from a long time of like checking and being, and my kids' practice is checking things and making sure. And I'm like, no, I need to be where I'm at. And if somebody is upset with me about it, that says more about them than it does about me.
An official policy may state 3 days, but if the culture within the department or your chair is very different than that, that there's the official policy and then there's the backroom conversations on what actually is the expectation. And sometimes they're very different.
Yeah, my dad's like, nothing, doesn't have anything to worry about except his health right now. And so, he's like, Dr. Murchison hasn't gotten back to me, and I messaged him this morning, and I'm just like, oh, these poor doctors in basket. Okay, all right, thank you for all.
Does that go back though to staffing? And from my experience going around, I work with the nurses and other departments with the stress first aid, and Kim is chiming in with the check you, check two to address those things. But one of the things I hear so much on that level is staffing. We don't have enough staff. Is it the same in the physician realm? And if there were more staff and a systemic issue, would those types of things be better able to be handled rather than one physician having to be in multiple places and answering inbox all the time.
There are definitely departments like radiology where staffing puts a huge strain on the team. The number of CTs we order doesn't change depending on the number of radiologists we have. Yeah, but also looking at staffing differently, I think might even be the sweet spot. So this whole like 30 hours of clinical work takes me 45 hours to do. So 30 hours of clinical work is going to be considered full-time is expensive, right? That's real. So, but probably a better plan going forward if we care about, which we do, but like if we're prioritizing the well-being of our teams.
I think as a physician, I can speak freely since I only got one more week.
Let it all out.
That's all right. Yeah, but the physician staffing is interesting because well, and actually, since I'm sitting next to the oldest man in the room, many of the departments are run by people, clearly with seniority, in terms of age and different generation. And, the pediatrics, and Lori, this might be helpful to you. When I took it on, we had enough transitions and things like that. Like you're talking about hospitals, there was no staffing model. And so, successfully now we do have staffing models for various areas, but that there's some truth to that. And, I know the nursing staff and, the clinical staff that we work with, I mean, they're been struggling, throughout the pandemic. Ever since the pandemic, I don't think the pandemic started it, but it just seems like it's made a difference. So, taking that filter of looking at the different generations and creating your staffing models, yeah, that's and I don't know how you deal with whiny parents. I'm sorry. You retire, that's what you do. You
I
retire.
got a little ways till that.
You guys are the best. This conversation's way better than the little workshop I planned. But I'll just introduce you to it in case you want to do it on your own. It's basically a look at what we're tolerating. And, the definition of to tolerate here is to allow or permit negatively by not preventing, to put up with. And so I like this thought of like, let's examine what we tolerate, because what we put up with, we end up with, and what we allow continues. So every now and then, looking at things to reevaluate the costs of what you're tolerating and your worth is a healthy practice. And I love this particular exercise because I love to find something that I've been tolerating and let it go. So I was going to tell you a story of some things I tolerate. Let's just say that I tolerate a lot of things. I'm a tolerant person until I'm not. And I think that stems for me because I put such a high value on personal relationships that when I'm in a moment-to-moment decision of should I tolerate this or should I strain the relationship, I just decide to tolerate. So that might resonate with somebody, I don't know. But yeah, when we continue to tolerate things, we create a high stress environment for us. And so the exercise, which we're not going to do fully, is to write down 5 things you've been tolerating. And then to kind of look at, is there one of those, the back of the paper kind of walks you through, is there one of those that you can let go of? And what would get in your way of letting go, and how will you do that? So feel free to take that with you. The conversation was way better than that, but I personally find the exercise fun to do because with so much on our plates, it's nice to find something that we're going to take off. All right. Any final thoughts? Such a rich conversation from you guys.
I do have more of a question. You had said that you felt it's really frustrating that all these systems are trying to improve the same things. And so we hopefully can be learning from each other. And I'm a little bit, I guess, not as knowledgeable about hopefully the Joy in Medicine program. I know that that's a recognition that we're doing certain things, but does it also provide, hey, here's, I don't know, a clearinghouse of ideas that people have done and how they've done it, so that we could go in and grab and say, oh, I think we could do that here.
Yeah. So the Joy in Medicine programs through the AMA and they really have been leading well-being work for the medical community. They have these a steps forward program that gives you like bite-sized modules. One of them is best evidence around how to make your people feel valued. The next one is it just came across our desk, that is looking at your time off practices, which Kim and I were like, oh, that's timely. And so they have these little bites. It's usually a webinar, a couple articles, some case studies of organizations who have done it well. So does anything else come to mind for you on resources like that?
I mean, specifically physician focused, that's probably the gold standard. I mean, I think some of the conversations that we've been in with the HHA and some other, the Virginia Health Innovations Group. But yeah, I mean, a lot of people are kind of in the same place. So I think the AMA is probably giving us the best guidance for that type of case study for what's really going well.
Okay.
The trade-off there is sometimes you don't get as nitty gritty of the details as you want, whereas the local kind of gives us more access to that.
And so people understand the joy in medicine. It's not just a stamp for me that gives us recognition. We have to put things in place that we don't have in place to get it. And so it really is a way for our team to advocate for Carilion and the School of Medicine in general to put things in place that are going to support us. So the next time we went up for bronze, we find out in March. No, and we applied in March, we find out in the summer. But the next time we go up for silver, it'll be a little bit of a stretch and we'll have to put some more in place. So. All right. Thank you guys very much. Appreciate you.